Today, I'm super excited to introduce two great, incredible clinical specialists, not specialists, but clinical awesome doctors today. We're going to be talking about full mouth rehab. Today, we're going to welcome Dr. Taher Dhoon and Dr. Chris Hill to the webinar. What's up, fellas? How are you?
Great.
Yeah, doing great. My parents are in town, so after the webinar, I'm gonna hop over there and get them to the airport. But been eating a lot of good home cooked meals for the past week.
Yeah, I bet you put on some LBs every time my mom's in town. That's all I do is eat.
Yeah, and a lot of butter and ghee in the Indian cooking too.
My favorite. My favorite. One of my favorite dishes is sog and dal. I can eat that all day long.
Yeah, yeah, those are some good staples too.
Yeah, for
Like
sure.
time to go on a fast after your parents leave, right?
I'm probably going to, man.
Chris, what's going on, man? Good to see you.
Not a lot, man. I'm super excited. I think we've got a good little webinar here today, and ready to just rock and roll.
All righty, sounds good. Taher and Chris, I'm gonna let you guys take over um uh the technology here. We have a PowerPoint presentation that you guys are gonna click through, I assume, and I will help man the chat room. And I'll probably have some comments myself and some questions myself. So why don't you guys take it away?
Well, you go, Tara.
Okay, well, like I was kind of introducing people to, Colorado Surgical Institute is having the full mouth rehab, where it's going to be a 10 over 10 type of approach. Now, at the end of the day, you should really plan on at least 14 over 14. But what we're going to be teaching is 10 over 10, restore that, get everything done, dial it in, and then go back and prep the molars later. Now, not every situation will kind of fall into that one scenario, but at the end of the day, if you want a treatment plan from that perspective, it's going to be the path of least resistance. Dr. Hill actually came out to my practice and we recorded about 5, 6 hours of content. And quite frankly, I mean, I was learning a lot while we were going through the presentations and just like the subtleties and nuances of how he approaches the cases really illuminated to me where he is just a supremely qualified educator and teacher. And then he was the mentor as my associate did a 10 over 10 case. And we filmed the whole thing and we got a lot of content there too. And I'm really happy to have Dr. Hill come on and really, create this program for Colorado Surgical. And I got to say, I mean, he is absolutely an expert in this field.
Thank you. Um, so I'm super like proud and honored to kind of like come along with CSI and kind of help build this out. I think there's a huge need, and when I heard Dr. Dhoon kind of talk about this, I really kind of said, like I want to be a part of this. I want to help. There's not a lot of places that you can actually go and do the restorative yourself. There's a couple courses here and there where you can kind of go watch somebody else do it, but there's really, really, really nothing like being able to do it live. So all those you guys that have been out to really know what it's like to do live patient surgery and to work on live patients, it's just a game changer. It's so much different than actually doing or than just sitting in there and kind of learning and lecture. So I've got about 45 minutes worth of material here, so I don't want to take up too much time. I'm just going to kind of go. You just kind of stop me whenever you guys kind of have questions.
It's your time, Chris. Can't wait to see what you got to show us today and teach us today.
You got it. Um, so I'm a big reader. I feel like everybody in this group is a big reader. Mark's always got a bunch of books that he's got on his desk. But this really is kind of one of my favorites, Atomic Habits. And as you'll kind of see, it's really all about systems. And, as James Clear says, you don't rise to the level of your goals, you fall to the level of your systems. I just want to show you that by putting systems into place, you can predictably tackle these larger cases. In the beginning, you start to implement the systems and things are going to be a little bit slower, but as you grow and you get that repetition, things just kind of fall into place. And I don't necessarily follow this whole system per se anymore as strictly as I used to. But certainly it's always something that I kind of fall back on. And it's sort of like the backbone of what I do. Just another great book. Actually, this was written by a doctor. Um, I read this a long time ago, and it just kind of always comes back into place. And I feel like full mouth is just like the definition of complexity. You've got records, you've got vertical, you've got aesthetics in there, you've got facial aesthetics, you've got occlusion, got a little bit of everything, and it's kind of a long list to keep track of. And even if you're highly skilled, it's easy to miss like those little things that can be critical issues later on. Gandhi argues that checklists don't necessarily replace expertise. They just support it by making make sure that the fundamentals are never skipped. That's why I just use a process, and essentially checklist just keeps me on point, and it just makes sure that myself, the lab, and the patient are all kind of heading in a successful direction. And we're
What I'll
always
say about that book is my mom was a pediatric oncology nurse and at Stanford Hospital, and they actually implemented one of Atul Gawande's checklists into their protocols, and she saw complications go down significantly since putting it into place. So and it's definitely a good read. It's a very well written book.
Yeah. One of my favorites.
um, well, I think the problem is like when we kind of go into like all on X, you have to go and learn it, and you go learn somebody else's system, and you kind of start doing, you know the protocol, you know how it goes. But I think full mouth is a little bit different because we learn how to prep crown teeth or prep crowns, and sometimes we just think, well, I'm just going to prep a bunch of them in a row, and so we don't always kind of learn systems, and we kind of like learn by default. um, I just want to make sure that you guys know that, like, if you put a system together, full mouth reconstruction doesn't have to be as challenging or as daunting as it is. Just go look at like All on X. You guys have followed a system. You know that you start here, you go here, you go here. You just follow your drills all the way through, and the success kind of comes. And then as you kind of you just start refining your systems. You don't always do all the steps. You know where you can take shortcuts, but you got to have the backbone. So um, we can make full mouth reconstruction as predictable as we make all on X.
And what I will say on that is Shivani Patel, my associate, she's been with me for about 2 years now, and I've helped her with some of these 10 over 10 and 14 over 14 cases. And after one afternoon with Dr. Hill doing this 10 over 10, one of our first bits of feedback was, I just never thought it could be that easy. And it's because the system is in place and he has the 1, 2, 3, 4, 5, and I was doing it 1, 3, 2, 4, 5. So even that subtle change in the order just, helped out so immensely with the whole process.
Yeah, she was great, honestly. Um, so when we get back into it, like the first thing that we got to do though is be able to recognize it, like, you know, be able to offer it. There's so many patients out there that it's needed. And we often think just as dentists, and we kind of just look single tooth by single tooth. We kind of start looking at quadrants. But now we're just kind of looking beyond that tooth, and we're kind of looking at the whole system. Teeth, bite, joints, the muscles, they all sort of work together. It's not bread and butter dentistry anymore. Bread and butter dentistry can be one tooth at a time, can be one quadrant at a time, but when things kind of start to be looked at holistically, you kind of start to realize that you got to treat it holistically. So when do we consider full mouth rehabs? The main reasons, just severe wear, breakdown of teeth, multiple feeling restorations, functional and aesthetic collapse. I'm probably doing more full mouth reconstructions for aesthetics these days than I ever have, where we're just opening the bite in order to be more conservative on the lower, as well as the upper. And I think as people get older and we're still healthy, we all still want to look younger and younger. So we're not necessarily seeing people just kind of like the picture that you see here. We're also seeing people that have really healthy dentition, that are just looking for aesthetic changes. So, but anyways, we got to start just kind of looking at things as engineers, and retraining the mind. I'm always thinking, do patients have bite issues? How do I rebuild the bite? Are they having functional issues? Now, not everybody sort of fits this bill, but you'd be surprised when you kind of start looking at it, how many people kind of, qualify or would be a great candidate for this. So I'm going to kind of run through my system, how we kind of bring patients in all the way from like marketing basically here, through consult and then through prep. And then I'll show you a couple of examples. But it obviously starts with marketing and getting the phone to ring and getting the right people in your practice. As you probably know, there's going to be these people that are already in your practice. But once you kind of get through them, we're going to kind of look at the people that are kind of coming from the outside. So one of the things that we do that I think is fairly unique is once the patient's on our schedule, we always do a preheat call. This is done by my new patient coordinator. It's basically her just kind of reaching out and introducing herself, kind of figuring out exactly what the patient's looking for. So we don't just say, hey, so Sally's on the, on our schedule for a consult for veneers. Like nobody knows what that means. Sometimes patients don't even really understand what that means. So this is a chance to just sort of figure all that stuff out on the front end, manage expectations, make sure the patient knows what they're coming in for. It's a 2-hour consult, so the patient needs to know the time commitment. We do talk about money. You got to be a little careful here. But you want to make sure that like the patient's not coming in thinking that it's going to be a couple $1,000 or that insurance is going to pay for that, because otherwise like it's just not going to go well. So we found that these preheats are kind of invaluable, and sometimes it allows us to sort of like allow the patient to sort of select themselves out of the consult too, and it avoids sort of like a time waste on our part and a time waste on their part.
What does that sound like, Chris? Are we talking about like, hey, listen, this is kind of the range of what we're going to be looking at, or what kind of language do you prefer?
Well, if we're kind of like in the realm of like, let's say On-X, like Colorado Surgical is kind of known for, like the first thing that you're going to probably ask the patient is, where are you at? Where are you starting? What sort of research have you done? What are you thinking? And then you kind of start to get an idea, like, oh, well, I have some bonding here and I was just hoping that I could kind of upgrade that. So I don't know that we're necessarily getting in there and directly asking about money and how much they make and what they're ready for and what their budget is, but it just kind of depends on how open that patient is with it. But certainly we can certainly give ballparks, can say, hey, patients in our office spend anywhere from $10,000 to $60,000 and $70,000. Doesn't necessarily mean that we're going to talk about all those things. I just want to make sure that you realize that, we might be talking about some bigger numbers here. We'll kind of figure out and tailor it towards your needs, but I don't want you to be surprised by that. But if you come in here and we start talking about that,
Yeah.
And
it's
there's
so
also
often that patients come in and they're just thinking that, such and such dentist told them that it was a $500 a tooth or $1,000 a tooth, and then we're way off.
Mm-hmm.
And there's also a lot of different companies you can use, like iSoft Credit Pull. Cherry has this, Proceed has this, where you can kind of figure out where the patient's credit score and their qualification is before they ever come in. And then that way you can treat the consults a little differently depending on credit scores and just information you have on the front end to understand how much like energy and time to give into a specific patient. Because 2 hours of a consult is a lot of office time to sacrifice for someone who's not ready for this type of conversation.
Sure.
Yeah. And just to be clear, it's not 2 hours of my time. I'm probably only in there for about 20 minutes maximum. If my new patient coordinator does a really great job, I'm probably in there for 5 or 10 minutes max. We've been doing this together for a while, so she knows what she's doing, and she kind of has a patient ready to go when I'm in there.
Nice.
This is basically the gist of our consult when they do come in. We do photos. We go through dental discovery, and dental discovery is just basically walking through the photos and kind of figuring out, what they have. We go through goals. So what do they want? and it's not like they're in there like looking for full mouth reconstruction. It's typically what do they want, as in I just want a better smile. I want to be more confident. I want to chew better. It's more of that like theoretical stuff. It's not necessarily like anybody coming in here like, hey, I want veneers. And even if they say, hey, I want veneers, then you got to like dig a little bit deeper and like, okay, why do you want that? And really kind of get behind the psychology of it a little bit. And then of course we're figuring out what they have. We figure out what they have by doing the dental discovery and looking at photos. And then how we get it. And how we get it is really just um, sometimes it's financing, sometimes it's money, sometimes it's getting over that sedation, are getting over that fear and getting them to sedation. So it's kind of breaking down those barriers. Um, we will certainly give them options. I certainly believe in the power of choice. I am not very good at telling people what they need. I'm better at sort of helping them discover what they want. And I will certainly guide them in a direction that I think is like best, but um, it's always been a challenge for me to tell patients that they have to do this or they need to do that. I have always been in the belief like you don't really need to do anything unless you're in pain. But my typical options is, do nothing, some sort of patch option. It may be like, hey, like now may not necessarily be the time. Maybe we just kind of do a night guard, or we got some general dentistry that we've got to do to kind of get cleaned up. And then, in the situation where it's a full mouth case, is that third option is usually a fix where it's like, hey, we can fix the bite, rebuild everything, kind of going along with their goals, matching to their goals, and letting them know like, hey, this is probably going to be anywhere between $50,000 and $60,000. And then of course we're looking for a decision. But the decisions don't always happen at the consult. I mean, it's a lot of information. And I'd be honest with you, my new patient coordinator will probably tell you she doesn't like when they make a decision at the new patient consult. So
Oh.
a lot of times that's just, they'll make that decision like later that week or something like that on a follow-up phone call.
And you glossed over something here where it's like the do nothing option. I think there's a lot of power in giving the patients the option to do nothing. It just shows that, like, hey, I'm here to really give you all the options. And I would bet you if you did an A and B test and you stopped presenting do nothing, your case closure would go down. Just because if you give them the option to do nothing, it's just showing, like, hey, like everything here in this practice is working. We're okay if you do nothing. But if you want to do something, this is the place to do it. So it's a really nice thing to offer every patient.
And sometimes it's do nothing, like, hey, you don't have to do anything now, but if you want to hold things like where they're at, like just do a night guard. Like, let's just keep you. And at that point in time, I'm just trying to keep them in the practice and then put them in through hygiene or something like that. And hey, when a time's right, we'll sit down and talk about this and we can go. So I like having a lot of patients in my practice that need full mouth, that necessarily aren't necessarily ready. At some point in time, they'll be ready. Some are saving. Everybody's a little bit different. Um, One thing that I think is really important is photography. So this is the most critical point um, in our consult, is just being able to take high quality photos, and then walk through these photos with the patient, kind of doing their dental discovery, figuring out exactly what they have. And then of course, we're taking photos on our after cases as well, so we can kind of show them, what they can get if that's what they want to do. That's my camera on the left side of the screen there. I use an R6 Canon with a macro lens and some Godox flashes. It's a sweet camera. I love it. I'm lost without it. I walk around with this thing all day. We have about 4 cameras in my office, and they're probably the most used piece of equipment that we have. Um, so my hygienist use it, my assistant use it, and of course my new patient coordinator and myself. So make sure you guys are using great cameras.
Is part of the pre-workup when people are going to be taking this course and they have some homework to do prior to showing up live in Greeley at Colorado Surgical, is part of the or the curriculum going through some photography lessons?
Yeah, I think the coolest thing is that, like Dr. Dune said, we were out in Greeley last weekend, and we filmed a bunch of stuff that you'll get about what 5-6 hours worth of pre-course videos. Some of these pre-course videos are, one is on photography, basically just how to shoot your basics, what you need for your basics, if you already have your basics, how to get better photography. And then of course, we'll just continue to teach that. We've got a couple other videos to make sure that like patient or that docs kind of get off on their right foot. So they come in ready to rock and roll.
Cool.
And anyone who's coming, we recommend they bring their own camera. And then if you don't have one, we'll be able to provide it for you. And then we'll be able to send you all the photography on your cases afterwards as well. And then we have recommendations on where to go and what to buy and, what's like the economic version that still gets, what Dr. Hill is talking about versus like what's the, Cadillac or Bentley of cameras.
Awesome.
I definitely don't have the Bentley, and I probably don't have the economic version. I'm somewhere kind of like right in the middle, and it works great. But you're right, you can be pretty cheap on those and still get good photos. So speaking of systems, we have forms for all this stuff. We walk through this stuff every single time. What you see on your left side of the screen, that's our dental discovery. So basically it's just a checkbox to kind of like walk through photos. You'll see in a little bit, like we will check these things off. We'll sit and make sure the patient's well aware of everything that's kind of going on. I treat a lot of TMJ. Not saying that like that should be your first case. But I do check for all these signs and symptoms. I don't necessarily check off all these like signs, but I definitely go through the symptoms. And then we do go through an option sheet. It is a handwritten thing that I will write out. And it's just pretty simple and straightforward. Patient goes home with that. And you'll see it in a little bit, but it's nothing special. We do scan all this stuff in, but then it does all go home with the patient. Once the patient like decides, then we schedule the exam. We do not schedule an exam unless they make a decision. Sometimes they've decided to move forward. Maybe we don't necessarily know what exactly they're moving forward with, but they've decided. So our consult fees are like $100. Our exams are about $450. So we don't necessarily do this always, but as soon as a patient says, "Hey, yeah, I'm ready to go," then we set it up. And at that point in time, we're doing radiographs, we're doing diagnosis, we're doing the CBCT to allow me to check for TMJ stuff. And of course, we're doing our perio chart. Basically, we're kind of going in and making sure that whatever we talked about in the consult, that we can actually go do it and make sure that like we do our perio, our x-rays, and make sure we don't have any RCT that's going to pop up on us or anything like that. So this is kind of just dotting the I's and crossing the T's. And then of course, we'll put together a treatment plan. If time allows and the patient's ready, we'll go through the financial arrangement. So what you see on these forms are my financial arrangement. It's 2 sheets. Obviously, it's not anything that comes out of my open dental. And again, it's just handwritten. And we keep it in layman's terms. So you'll see in a little bit, it'll just say 14 porcelain restorations, or it might just say full mouth reconstruction with whatever the patient's kind of getting. And we keep it pretty simple. And then of course we go through a treatment sequence. We have this pretty well down. You guys know how treatment sequences go. Sometimes we just kind of do an email exchange back and forth, kind of putting these together, but everything is planned out from prep day all the way down to our final photos. So that we kind of have truth in scheduling and we don't run into a point where we're like, oh shoot, we need to get this patient in for a seat, but we're all booked up. So we might sit down and schedule 6, 7, 8 appointments per patient. All right, I'm gonna keep going. So then we go to the records visit. At our records visit, we're always going to talk about smile design. All these cases aren't necessarily about smile design and aesthetics. Some of them are functional issues. But at the end of the day, like everybody wants to have a good smile. So we're going to talk about smile design. Mark, you asked about, about photography, but we also have a smile design video that we're going to be sending out ahead of time as well, so that you can have these conversations with your patients before you get to the course. What were you going to say?
No, that's great. I was just I was affirming that that's pretty cool.
Yeah. And then we'll do a smile test drive. So basically, I'm just using Flowable here and kind of like mapping out what I think the patient's looking for and sort of like what I have for a vision. I do this in about 30 or 40 minutes. And you can see this patient here, we did a smile test drive on. She's wearing the exact same thing, obviously. And so these pictures are probably about an hour apart. Picture on your right side of the screen is kind of our finished product. Once she's kind of happy with it, we'll scan that. You can certainly take impressions if you're still taking impressions, but we scan that and that goes off to the lab so that they have a really good idea of what the patient's looking for, what I'm kind of looking for. It's definitely not a polished up version. So I send it off to my lab and he'll polish it up. I may still kind of come in there and tweak it a little bit on my lab script. And then, of course, at the end of the day, we're deprogramming the patient and then putting them into a bite. So what I mean by deprogramming is that for a lot of these patients, they have these dysfunctional bites that have got them into these bad places to begin with. So we're usually doing some type of deprogrammer, whether it's a quick splint, a Coist deprogrammer, if you're familiar with that. I personally use a TENS unit. So if you guys know, like a little electrical pulses right over the joint, you can do that in about 30 minutes. So I do that because it's quick and I've just been trained that way. But I always think that if we're going to rebuild the bite, don't rebuild it in the same position that it started with, because that sort of got them in the bad place to begin with.
And then for anyone coming through CSI, we will send you the quick splint as STL. And if you don't have a 3D printer, then we'll go ahead and print off a whole kind of like bag full and we'll mail them to you. So you have it ready for your patients to get all the deprogrammed bites and everything ready. And then of course, for anyone in the DSN family, if you want the STL, we're more than happy to send it over.
And quick splints are simple. They're just a little jig that kind of goes over like the front 6 teeth. You fill it up with bite registration, and it separates their back teeth. They wear that at night for, I don't know, 3 days, 4 days, just to kind of loosen up those muscles a little bit. And then they come in usually in the morning wearing it, and then we take our impression of our bite and then scan that impression. So it's not complicated. That is also another one of our videos that we include. Everything then goes off to my lab. I do a full RX. All my photos that go, I don't inundate my lab with 20 photos. I just send him the ones that I feel like he needs and kind of show what I need. And of course, I'm getting back mock-ups that are digitally mounted. I still use articulators. I use the Stratus from Ivoclar. Some of you guys don't know what those articulators are. I don't have any anymore. I still love articulators. That's just the old guy in me. And then of course I'm getting bite stints back, a reduction guide, to make sure that we're just being as conservative as possible. So we're just following a path basically. And then we do a dual arch temporaries. I think Dr. Shivani was a little bit nervous, but we do the tops and the bottoms all at once in about 1.5 minutes, 2 minutes. And it's pretty seamless. On the right, you'll see that's my Smile Design RX. It's something that I created with my lab. It's everything that I want on it, everything that my lab wants on it. It kind of goes back to the checklist manifesto. Like it just makes sure that I don't miss anything as I kind of follow through it. And then we do the preps and temps. There's nothing magical about this day. I do the upper and lower and get it all completed. I scan the bite using the bite stent, and I'll show you the bite stent here in a minute. Photos, prep shades, all that good stuff. And then the temps are placed. I say choose shade wisely, mostly because, there's Luxatemp, which is a BL2, some guys don't want to be that bright, so I'll usually use like an integrity bleach. That's going to be like a BL3, and then sometimes we even use a B1 on old guys usually, but women they typically want the Luxatemp BL2. And then this is my RX for porcelain. Again, this was between me and my lab that we created this, and it just keeps me from forgetting things. I fill this out, my team doesn't fill this out, but these days it's pretty quick. So once we do the preps, about a week later, sometimes a day or two, I'll see the patient just for a smile approval and bite check. At this point in time, I'm just making sure that the aesthetics are on point. I'm just making sure the bite looks good. And I'm making sure that the patient's happy. And we're going to go ahead and make any changes at this level that we need to. As you guys all know, you can add to bisacryl pretty readily. Even if it chips off, like no big deal. We'll just make sure that we've got what we need. We'll scan that, and once the patient's happy, we will T-scan the bite. For those not familiar, it's just a digital occlusion, just to make sure that they're comfortable. But remember, the bite's already been sent off to the lab, so they already have that bite. The T-scan bite just is really just to get them comfortable at this point in time, and to show off a little bit of technology, like, hey, I'm going to make sure that this is not only like you telling me the bite is off, but I'm also going to subjectively measure this bite for you. We do choose shade at this appointment. I keep it pretty simple when I talk about shade, depending on the level that I'm at, a BL1 or 2 or whatnot. And I just kind of say, are we happy where they're at? Do we want to go a little bit brighter? Or do we want to tone down a little bit? And that's about as deep as I get into it. And I'll probably say like 60-70% of the time, they're like, yeah, this is perfect. Every once in a while, you get these big coffee drinkers and they're like, well, I liked them when they first went in, but now they're a little bit darker. Can we go back to that shade? And immediately I know where we were at because I know what we used. So, and then of course we get them to basically sign off on the temps. And then we scan them. This photo here, I do this in Keynote. You can do this in PowerPoint. We will give you all of this too. These little like tooth overlays. So this is after I modified her temporaries and added some length. As I was looking at it, I was like, there's just some other things that I want to do. And I don't dial every little detail in, nor do I let the patient get too marred in the details. So I'll do this sort of on the back end. You can see all the little bullet points that I've made to my lab that I want fixed. So this ensures that like I'm designing this smile and the lab is sort of following my prescription. We're not necessarily just sort of following whatever the lab gives us. I know a lot of people are sort of used to like just sending it and just saying, hey, wax up like 6 through 11. Not necessarily doing that. I'm giving them sort of the blueprint on the patient's teeth, and then I'm dictating everything else that I want to them. Then we go to cementation visit. I will usually remove half of the uppers and then try them in. I know this photo isn't that, but typically on the left side of the screen, you would see temporaries, and then on the right side, that's my porcelain there. And usually I'm just looking to make sure in a verification process that my lab followed exactly what I was looking for. So my temps should match my my porcelain. And sometimes it doesn't because maybe I asked for a little bit of length or this or that. And I can verify that here too. Again, it just keeps me honest. It keeps the patient on, or it keeps the lab honest. So those are my preps on the left side of the screen there. You can see I'm pretty darn conservative. And then we try everything in, we cement the uppers. Then once we cement the uppers, then we remove the lowers and try in. We kind of go through the same process, cement the lowers. I'm at a point now where I won't say never, but I almost never check my bite before I'm done. That there is a little bit of a pucker factor when you do that the first time. But once you get to like working with your lab and you guys know exactly what's going to happen, and you know that you followed all your steps, you know that like you don't got to try in the back teeth and start adjusting the bite and anything like that. Like I just know that like everything is going to work and everything's going to fit. So I will do a little bit of a bite adjustment if I have like a major issue. Usually it's like a cusp of a second molar that's kind of sticking up or something like that. But nothing major. If I'm close, we leave it until the patient's back. This is usually at the end of a 4-hour seat appointment. The patient's numb, sometimes they're sedated. So I don't dial the bite in at this point in time. And then our final appointment. This is the finishing and the photo appointment. We verify patients happy, any concerns. I will still do some aesthetic adjustments if necessary. Usually that's like rounding a corner, you know, cleaning up some line angles. We're cleaning up cement at this point. We're typically taking x-rays. They will see my hygienist as well to clean up cement, anything that I missed. I do T-scan them because as much as I believe them and then them sort of like leading me through like what's high and what's not, T-scan will tell us exactly where it's at. So if you guys haven't used T-scan before, it's really cool technology. I get that you can do it with articulating paper, and that's what people kind of say. It's just a really expensive articulating paper, but it works. And hopefully if you followed your systems all along, you get high fives and hugs at the end. And then you get pictures like this because the patient's super ecstatic and they're happy. And it's just, I don't know, rewarding. Dr. Dhoon, I know that you see these types of patients all the time, like, you know, kind of just transforming them and with implants and stuff like that. It's rewarding at the end, right?
It really is. And it was interesting because in the beginning of my career, that's not like why I started to do these more complex procedures. And then as you start to have these moments with the patients time and time and time again, it just kind of fills up your soul, and it gives you the energy to kind of persevere through those things too. I did have a question for you. You told me something at the office the other week about your hygiene protocol for your patients. Like if they have perio or if they don't have perio, could you share that with the docs? Because it was just really unique, and I'm going to actually change my protocol to mirror yours.
So if they have perio, like we just started some lady on it now, and obviously it depends on how much perio they got going on, right? Sometimes like they've got too much perio, you just have to slow it down, and it may be a 6-month process. But assuming that, let's say this patient that we saw today, like generalized like 3 to 5 millimeter pockets, notable calculus. I've just got to get everything under control. I don't necessarily have to wait 3 to 6 months to start, but I got to make sure that like I see some resolution. They start to see the inflammation go down. Obviously, if we have issues of pus, like that's not going to go well. You can't put a bunch of temporaries over pussy gum tissue and expect it to heal. You also can't expect it to not be cementing in blood. That's no fun either. Scanning in blood is not fun either. So I think in the beginning of my career, I probably seeded a lot of cases where I was managing a lot of blood. I just don't do that anymore. We just have a hygiene protocol where we clean them up on the front end. And even if they don't have perio, we're still doing a pre-prep prophy. A lot of times we'll do a pre-seat prophy. So it cleans them up while they're in their temporaries, particularly full mouth restorations. You've got a lot of interproximals there in the posterior that just gets crap kind of underneath it. And on the end, we're doing our post-seat prophy, and that's kind of coming in and cleaning all the cement up. And if for some reason it's a perio patient, we're kind of putting in these little spots for their maintenance. So ours is typically, we do all of our scaling and root planning. 3 weeks later, we have a supportive visit. 3 weeks after that, we have a supportive visit, and then we go into 3-month perio maintenance. So we just sort of time everything out in there to kind of work. So
Hey, Chris, going back to the temporary seat appointment, are you sending them through kind of the same protocol? Are they seeing a hygienist to get rid of any temporary cement that you might have missed?
well, typically I'm just kind of doing these shrink to fit. So there won't be any cement per se.
Okay.
My job in putting the temporaries in is kind of taking like a flame diamond and really diving into the interproximals and making sure that they're pretty darn clean in there. You're gonna get some areas that are gonna get just stuff trapped in there naturally a little bit more than others. We do provide an electric toothbrush, and we do provide a water pick. And my hygienist will sit there and go through the water pick specifically with them. We see them about a week before we seat as well. So if for some reason we've got some puffy gums, a little bit of bleeding going on, we can kind of tackle that and just say, hey, you've got about a week to get this cleaned up. And 9 times out of 10, they do. For that 1 out of 10 times, that's what super oxal's for.
So yeah, actually that was going to be my follow-up, and not to necessarily take you off a tangent into the clinical, but I know dentists like clinical kind of solutions sometimes. Let's say you're at the cementation date and you do have hip and bleeding. When's it appropriate to use a diode? When's it appropriate to use like anesthetic versus superoxyl versus Traxident? Do you have kind of like a checklist on that? Like, okay, these are the areas where I use certain things.
Yeah, so I basically have a hierarchy. It starts with something like viscostat. Viscostat clear. Don't use viscostat. What happened there? Is that me?
I don't know. Do you lose your PowerPoint?
I don't think so. Maybe.
Sorry, I think that was me. If you need it, you just should be able to share it back. I apologize.
Okay. Is am I paused? Is that how do I unpause that?
Ashley.
It's a great question. It just said it started sharing, double click to enter full screen mode. That's what we can see on our end. I don't see any pause. Can you stop sharing and reshare again? So sorry about this. Literally never happened.
Can you see my screen?
No.
It's a double click to enter full screen mode. It said it has started sharing. There we go. It's back now.
We can see it.
Okay. Okay, well, I'm gonna fly blind without my notes here. What were you saying? I'm sorry.
Dr. Dune.
You're muted, Dr. Dune.
We're gonna do this.
Oh, my hierarchy. I know.
Like hemostatic agents, yeah.
Yeah, so I have a hierarchy. I'm typically using something like viscostat. Just don't use the ferric sulfate, so don't use the brown one. It can create sort of like scuzz underneath your temporaries. And then I will typically roll to like something like Traxident. I use dries. I think it's pretty similar. You can do that. I would say 9 times out of 10, that'll do it. If that doesn't do it, I'm typically going to superoxyl. If superoxyl doesn't work, like we've got other issues kind of going on. Superoxyl will sort of like, just be careful with it. It's just high concentrated hydrogen peroxide. It'll blanch the tissue like crazy. And then after that, like there's every once in a while, I've got to go into a diode. You have like these deep margins and on some old crowns, and you had a bunch of temporary stuff in there, and it just caused crappy tissue. I might go in there and just clear out that tissue with the diode. So that's sort of my hierarchy. I don't typically like to use anesthetic if I don't have to, because I find that as soon as you poke them with like 1 to 50K, then all of a sudden other areas start to bleed.
Yeah.
So, but yeah, it happens every once in a while. But then when that happens, you kind of just fall back to your systems. You have a conversation with your hygienist. You have a conversation with your assistants and say, hey, we don't want to do this again. How do we do this? Let's figure it out. So just kind of going back and tweaking your systems until you get to a point where you're like, you know what, this is pretty simple. This is pretty easy. It's predictable. And predictability just kind of lends to great results.
And then one more question, your shrink to fit. Can you just like in 1 minute give me the how you do the shrink to fit, and do you etch and bond underneath, which teeth you do that on? About like the tip about air drying the bonding. Can you just kind of go through that real quick?
I'll show you here in a minute.
Oh, awesome.
So I've got 2 cases. I'm going to go through these 2 cases really quickly. I want you guys to see how like I basically take everything that I just threw at you and just kind of apply it to both of these cases. So this is a patient that he actually was a virtual consult. So I do virtual consults, and this guy kind of came in through a virtual consult. He really wanted to figure out like what he could do with his bottom teeth. He was from Boston, so he kind of flew in and out of from back and forth from Boston to St. Louis. That's where I'm at. I think that he has family or something like that in St. Louis. So, and he told me, he's like, and frankly, it's probably cheaper in St. Louis. And I'm like, yeah, probably right. So anyways, you can see his bottom's kind of failing. He's obviously got some bone loss going on the top. Doesn't look too hot either. These are just some sloppy notes, but this is notes from his preheat and his consult. So my new patient coordinator, I promise, is super organized, but she always has a purpose of the day, health history, goals, PICS, CT, FMX. So if it's a patient that once is looking into implants, I will take a CT that day. I just got to figure out what's kind of going on. We obviously take a little bit of notes of kids and there you go, kids and grandkids in St. Louis. So just different things that they kind of tell us. And then of course we do dental discovery. You can see all the things that we kind of have check marked on him. We do next appointment. We're going to go through a comprehensive exam. We're going to do a bite test. We're going to use a customized hygiene visit. So he ended up getting scaling and replanning. And then kind of next visit depends on the options. I'm going to have to move my little screen here. So you can see this is basically my 3 options: wait it out, do nothing, replace lower, do floater, snaps, or fix. So I usually speak in layman's terms. A floater, you guys know, just as a regular denture. Snaps, obviously, it's got some locators, or we can go to fix. And then, of course, let's fix it. Let's restore the upper, replace the lower teeth. This allows us to balance the bite and whatnot. So pretty simple. That's as much as I filled it out. That's actually my new patient coordinator's writing. So sometimes she really goes ahead of me when she knows what's going to happen.
I've never heard it called a floater before, but I'm totally stealing that verbiage, man. That's great.
Patients just understand what it is, right? Here's a CT just to give you guys an idea. His bone loss on the top is not that bad as it looks. This is just a reconstructed CT, so it doesn't always look that great. But here's a little bit of his progression. So this is where he started. This is him and his temporary dentures when he just decided on the top, or just decided on the bottom teeth. And then he called us about a week later and he said, you know what, I want to do the bottom or the tops. We had scanned him already, and we scanned the lower denture because we kind of thought that he would do that. So I had all the information that I needed. So everything got sent out to my lab. Those are my preps doing the top teeth. Then you can see he's still in his temporary on the lower. These are his uppers. Those are shrink to fit. I will show you on the next one how I do that. But we just simply we have a stent created by the lab, like a putty matrix that slips over that. It probably doesn't come out looking that nice, but it comes out pretty close. And then there he is final. We did not deliver these at the same time. I just took a picture. Anyways, porcelain on top, all on X on the bottom.
And this is one of the reasons I'm so happy that you're bringing all this information to CSI, because oftentimes you'll see that upper arch edentulated, and this is a beautiful outcome. It's in my estimation, the most appropriate outcome for them, and everything the patient wanted was resolved without, taking all the teeth out up top. So this is exactly the multidisciplinary approach we want to teach.
Yeah, and his teeth, although he does have some bone loss, like we're super solid. And we walked through that path with him of like, hey, we could end up doing this, but he just didn't want to lose his upper teeth as well. And I often think that, like, we talk about like the super GP. To me, this is like the ultimate GP, right? Like you can take anything and fix anything. You can fix them with implants, you can fix them with porcelain, you can fix them with both. I just think it's a really cool way to be a restorative doc, and you don't have to be a clear choice where there's just sort of like only one option. All right, last case. This is an aesthetic case. This patient said that like within the last year, like she wasn't able to see her teeth. Now, I don't know that this happened necessarily within a year, but I kind of partly blame age on it. But I mean, she showed me pictures from like a couple years prior, and she had this full face, but you just start losing elasticity. And sometimes some of those years, we start losing a little bit more than what we liked, and things kind of accelerate. You'll find that out as we age, right? So you can see just pretty healthy teeth, pretty healthy gum tissue. It made this pretty straightforward as long as you know what you're doing. Here's all of our stuff. A little bit differently. Like, again, we go through our checklist, of course, right? But doesn't mean we use everything. Sometimes we use something a little bit different, but you'll see here, we kind of got our goals. Wants to look good in pics, wants to improve teeth and see teeth. It doesn't say anything about veneers. She wants to maintain her youth. We do go through signs and symptoms. She doesn't really have any signs and symptoms. A little bit of sleep issues, so we did get a sleep test. It didn't show anything. And then, of course, our treatment options, ortho, which on a patient that's her age is like a no thanks. Most or all of the top teeth. Obviously that's going to be about $30K, or we could rebuild the tops and the bottoms to show as much as possible. And that's going to be about $60K. So you can see we kind of put on, the patient knows the cost. So when they schedule the exam, it's like, okay, I want to do full mouth. Like the first time they see the cost isn't when we go over the financial arrangement. They know what they're getting into. So you'd never want to get to financial arrangements and them not know the cost, and all of a sudden, wait, whoa, $60,000, like that'll cause sticker shock. So we're a pretty transparent office. I don't shy away from my fees, and we're pretty upfront with them. Here's our FA. Pretty simple. This is handwritten, porcelain restorations on all teeth, post-op visits. I don't think, we had 2 visits of conscious sedation. So she did this under sedation. You can see our fee is $65. Obviously give them a courtesy discount. And so this is a $61,500. There's $61,500 worth of treatment. So just kind of walking you through, obviously on the left side of the screen is her normal smile. The right side, sorry, it was a little dark, so I tried lightening it up, and then it just turned weird. But that was just flowable on her teeth. I did kind of canine to canine. I added a little bit on her premolars, but we just kind of ran out of time, and we were happy where we were at. So that all kind of goes to the lab. And then, of course, I'm giving the lab more instructions. Of course, I'm sending my RXs, but these are so much more valuable than just a written prescription. So that's kind of telling the lab exactly what we want. This is just a snapshot of my keynote. So I use this little line here that I can move around to make sure that everything is level.
And then for all the full arch docs, I'm actually going to take Dr. Hill's prescription here and do it even for final prosthetics because it's all the stuff still marries together really well.
It applies, right?
Mhm.
So here we did a Coist deprogrammer. So it's just basically an anterior midpoint stop appliance. If you guys have ever heard like AMSA or something like that, doesn't have to be a Coist, but it just stops right here. And the rest of it sits on the palate. These things are nice because the patients can wear them kind of all day if they have a lot of joint issues. I don't usually use this, but I just used it because I don't know, we were creating this course and kind of wanted to show you what it looks like. But it does cost. So if you have a printer, it's fantastic. But if you do it at a lab, they may charge you $300 or $400. So that's kind of why we do the quick splints. Bottom is my preps on the top and the bottom. So you can see how super conservative those preps are. Didn't even break contact in almost any of the teeth, I don't think. Basically, we're just overlaying, we're adding here. So not only are we preserving, saving teeth, we're preserving enamel. Here's my bite stent you asked about. Basically, that just holds my bite at the vertical. And I can reline this with bite registration as I need to, as I start prepping teeth. Here, I didn't really adjust the occlusals at all, so I didn't really have to reline it all that much. You weren't asking about that. You were asking about the temps. So this is what I often do because these were relatively thin preparations. I just spot etch these teeth, dead center of the tooth, about 1 by 1 millimeter, maybe 2 by 2 millimeters. So if something sticks, I know exactly where I need to go to get it to clean off. If I feel like I need a little bit more retention, I'll take a tiny little micro brush with not a lot of bond on it and put it right dead center on that etched spot. So I might put it a little bit here and I might come back here and bond. I do not air thin. If you air thin, that bond will go everywhere and you'll be drilling off your temporaries like crazy. Here, I will usually just put a slit down the middle of the tooth and then just take like crown removers, and that'll usually pop off. Every once in a while, I've got to come back with like a red diamond or something like that and just buff it out, kind of like if you were taking off Invisalign buttons. Is that what you're talking about, Dune?
Yeah, thank you.
This is the full mouth, our dual arch splint. So we're tops and bottoms. A lot of people are probably used to utilizing some type of stent when they're putting temporaries in. This is doing tops and bottoms at the same time. This is immediately after removing it. And you can tell how like well adapted that is to the tissue, how clean that is. And I will say the healthier her gums are, the easier these things end up being. So she just happened to be a great patient. This is our smile approval. So she's coming in looking like that. And then after you guys saw this photo earlier, but afterwards, I'm like, well, I used this guy, Bob at Williams, and I just said, hey, can we bring everything down, build everything a little bit more out, bring everything down 0.5 millimeter. And then I've got a couple angulation issues. He was a little short there. So, and that's our final product.
Looks great.
That's beautiful.
Yeah. So there's our top and bottoms, or before and afters on that left side. This is a calibrated ruler on the right side, just kind of showing you my vertical increase. So I was at about 14 millimeters on the top, and we ended at 18.5. So we opened her 4.5 millimeters. But you can just see the distance from here to here is totally different from here to here. So anyways, that's what I got. That's my system. So as you guys know, like we're teaching this system. It's going to be 2 weekends, November and January. It is a live patient prep, so we encourage you to bring your own patient, but in true CSI fashion. They have a decent amount of patients readily available. So if that becomes a barrier, you can borrow one from CSI. But basically, we're going to give you everything FMR from A to Z, live lab interactions. Obviously, there's some added stuff that we're doing, marketing, photography, mentorship, all the things that you can kind of expect from Colorado Surgical and what Dr. Dhoon's kind of created. You have anything to add there, Dhoon?
I mean, I guess the only thing to add is we've been saying no to so many patients who come in through CSI who want full arch, and this is the program. So we have a Rolodex full of people who are just waiting for this program to roll out. So I'm just really excited.
Yeah. Here's just a couple of things that you're going to kind of learn real quick. Obviously, we show you how to do records, understand vertical dimension. Vertical dimension will be part of the pre-course photo or pre-course videos, as is photography, as well as smile design. You've just got to know these things from the get-go and can't learn them halfway through the course when your patient's already there with you. So we're going to give you sort of the tips and the tricks ahead of time. We'll teach you how to prep and temporize full arch cases with efficiency and ease. Obviously, you saw my preps. I'm not aggressive. Minimal prep means less time in the chair for me and less time in the chair for them, and teach you kind of how to manage the bite. I think people get a little nervous about managing that bite. We'll teach you how to design and deliver. The scary part typically is that delivery day. We'll teach you how to go about doing this fairly systematically and with low stress. I won't say no stress. There's always stress with delivery. But we'll teach you ways to kind of clean that up. These cases are all just cases that I've done. We will show you cementation day, case finishing, managing expectations. Probably the hardest thing that we do is just manage patient expectations. We'll show you how to do that on the front end so you don't have issues on the back end. And then kind of like we talked about, it's just less patients and more fulfilling. And it's a cool way to be able to tackle complex cases. This is that lady's before and after. You can just see how it kind of thins out her face. Give her about 6 months. Those masseters will chill out too. And she's just gonna, what I usually tell patients is like, it's just gonna allow you to age gracefully. And somebody her age likes to hear that. We'll teach you how to market and grow your practice. And understand how virtual consults can unlock. So I'll show you how I utilize virtual consults to do this. Here's the case that I kind of showed in the very beginning. We did some crown lengthening on this guy, but this could have easily been a full arch case in somebody like all on X in somebody else's office. And then just the extra, obviously, as you asked Mark, we have pre-recorded videos to get you some one-on-one with Bob, and then mentorship as always, and then of course discounted future courses. And there's the logistics of it.
November 7th, 8th, 9th, and then January 9th and 10th at the Colorado Surgical Institute. Dr. Dhoon, if they want to hear more or get more details, are they reaching out to you directly or Chris?
Reach out to Chris Richards from coloradosurgicalinstitute.com for logistical scheduling type things. And then clinically, Dr. Hill will be your point person. And then consider me as his star running back. He gives me the rock, I'll run it down. If not, I'll just kind of run the plays that he calls.
Very nice. Very nice. Well, Chris, awesome job. What's the best way for people to reach out to you directly?
That right there. So just DM me on Instagram. That's the easiest way to get a hold of me. If you DM me on Instagram, sometimes we just switch it over to text. I can kind of put my text or my cell phone on here. I should have done that, sorry, but that's the easiest way. Just reach out on Instagram. All my stuff is on there. I'm pretty readily available. As Dr. Dhoon will tell you, I'm just kind of an open book. I believe in abundance and believe that we just need to help each other out and support each other. And that's kind of what I'm here to do, and part of the why we're putting this program on. So, but there's our scannable link. I have made everything available to you that I showed you in here, from my new patient call sheet to my prescriptions, to my option sheet, although relatively simple, but a whole folder full of stuff, if you guys want it.
Great. Awesome stuff. Well, thank you so much, Dr. Hill, Dr. Dune. Thank you, everybody that lasted the whole time here. Nice little group here inside DSN and watching the webinar live. This will be available for anybody that wants to watch the recording inside DSN. And Ashley, anything that we forgot to mention?
Nope, you nailed it. That's all.
All righty. Dr. Dune, did you want to say anything about the frenectomy course?
Oh, if anyone's interested in frenectomies, I think we're going to bump that to November, but we have a live patient lingual frenectomy course where you'll learn how to just do all the evaluations, learn where the genioglossus muscle is, learn what to cut, what not to cut, and then just how to kind of build your practice from that perspective as well.
Awesome. Awesome. All right, everybody. Have an awesome, awesome day. Dr. Dune, Dr. Hill, great to see you both. And we will see you in November and in September.
All right,
right.
thanks, guys.
Take care, everybody.